Assalamu alaikum. Good morning, good afternoon, and good evening. I hope everybody is doing great. So we are moving on to our second lecture of tonight, which is going to be about the lower limbs. Yeah. So today we're going to talk a few most important and commonly tested topics about hips, knee, and lower limbs. So lower limb orthopedic for the MCQ one, learning objectives is obviously the same thing. What are the cases that we are covering? So we are going to focus on osteoarthritis today, meniscal tear, ACL injury, patellofemoral pain syndrome, trochanteric pain syndrome. So these are the things that we are going to focus on today. And example principle, first localize the pain, then decide whether it is degenerative, mechanical, intra-articular, ligamentous, patellofemoral, or lateral hip soft tissue. All right, so let's move on. So pain location, time, red flag, and best steps. Today, we're going to focus on the hip, which usually the patient will come with groin pain. Groin pain, hip. Lateral hip, usually it is going to be trochanteric in origin. Anterior knee is usually patellofemoral. Joint line, meniscus. So these are, in terms of location, very important clues that if you see it in a clinical vignette, for example, if somebody comes with a groin pain, always thinks anything about hip joint abnormality. So the joint is involved in groin pain. If someone says that the lateral part of my hip hurts, so most likely it is trochanteric in origin. If someone says I have a knee pain, but if you're asking which part of the knee, anterior, and it is usually young adult, usually athletes, so think about patellofemoral. In terms of location also, if the meniscus is involved or damaged, usually the patient will have pain in the knee, but the joint line. Now, in terms of time and course, chronic activity pain, usually osteoarthritis. So it means if they give you a clinical picture or a clinical vignette about somebody that who has chronic activity pain, especially, sorry, I chew my lip and it hurts now. All right, so chronic activity pain, so it is osteoarthritis, especially if it is a woman, if it is an elderly, if the patient has a chronic pain. Acute pivot plus pop, if somebody comes with a knee pain, which the patient was, it happened, I mean, the injury happened due to an pivot or intense exercise, and the patient heard a pop, and then the patient starts to feel that the knee is giving away. That is more likely to be ACL, acute cruciating ligament tear. If the injury happens while the patient foot is stable or stationary and the knee has been twisted, usually it happens in a young adult athlete during intense workout or exercise, for example, soccer. Usually it happens in soccer. But if it happens, the meniscus, it is going to be meniscus tear or damage, right? But meniscus tear can happen in elderly due to degeneration. Especially, it is very strongly associated with osteoarthritis. So please remember that osteoarthritis is very strongly associated with the meniscal damage. So if you have somebody who has chronic knee pain, and now the patient also have locking knee and crepitus, then it might be the meniscus due to the degeneration that happened in consequences or as a result of the osteoarthritis. But in a young adult, it may happen during intense exercise, or it can happen due to injuries, motor vehicle accident. Red flags: hard swollen joint, inability to bear weight after trauma, true locked knee. When we say true locked knee, it means the patient flexes the knee and cannot extend it. It becomes locked. Let's say if this is the knee, the patient flex it and then it get locked here. So if the patient has locked knee that cannot be straightened, then in that case, you have no choice but to do the surgery. Neurovascular compromise, obviously, that's a red flag. So best step, conservative always, but if it doesn't help for a stable and overuse osteoarthritis, we always, for everything, all the musculoskeletal condition, we usually start with the conservative if the patient is stable, right? Same thing applies for the osteoarthritis. Image refer when the red flags are mechanical blocks. So if you have the red flag, then you have to escalate the investigation, the management, the treatment. Most MCQ 1 lower limb cases are solved by matching one key clue to the correct structure. So pain location, if it is in groin, it is usually hip. If it is anterior knee, usually anterior knee will be right here and here. Joint line is going to be this line. Femoral, patellofemoral pain, and also time. This is how it happens in osteoarthritis. Acute pivot, usually like somebody who is playing soccer, twist and lock, meniscus. It also happens usually, if it is adult, usually it happens due to intense exercise. It is an elderly, it usually happens in someone who has osteoarthritis. So these two are strongly associated with each other. These ones I think I did mention, right? So let's start the osteoarthritis. Typical patient. Usually for osteoarthritis, if they want to test it, usually they give you an older patient. Usually it will be a female. I'm not saying it is not happening in male, but it's more common in female. Usually the patient will be obese. Again, it could happen to anyone, but usually it will be obese. And also the typical patient will have a joint risk factor, chronic gradual pain in knee, hip, hands, or spine. The symptom, the pain worsens with activity and betters with rest, but functional limits with the stairs and walking. The patient has a stiffness, but this stiffness is different than rheumatoid arthritis. It is less than rheumatoid arthritis. It is less than 30 minutes. If they give you a scenario about osteoarthritis, they usually give you a female, let's say 55, 60, and the patient has knee pain. Usually they mention the knee because osteoarthritis is very specific for the knee, but it can happen to the hip, to the hands, spine, but usually most characteristic joint is the big joints, and they will choose the knee more often. And the patient is obese, and the patient has pain while patient is walking, going upstairs, and when the patient is squatting for a long period of time. And also the patient, when wakes up early in the morning, the patient has stiffness, which lasts for 15 minutes. So less than 30 minutes. So pay attention to that. So these are the clues. Exam crepitus, bone enlargement, reduced range of motion, varus valgus, deformity, no, fever or hot joints. For the X-ray, I made a mnemonic to make it very easy for you guys to remember. Remember the 4S. 4S is the radiographic findings of osteoarthritis. The first one is the space narrowing of joint. Space narrowing of joint. The second one is subcondylar sclerosis, subcondylar cyst, and the last but not least is osteophytes. Okay, so this is how I remember it, but I let you guys to decide on your own the way you want to remember it, because sometimes they might give you a scenario. It will be vague, but they will mention the X-ray finding, which helps you with the diagnosis. For example, they may give you someone like 45 years old male. See, it's not female. So the first thing that comes to your mind, osteoarthritis is usually happening in females, so it's male. So it is automatically ruling out the osteoarthritis. The patient has knee pain. The patient has, for example, stiffness around 15 minutes early in the morning. And then he did an X-ray, and the X-ray shows space narrowing of joint. Now you know, no, this is specific for osteoarthritis. You come back to osteoarthritis. So remember, sometimes they may trick you or distract you from that diagnosis, but then they throw another thing to help you out to get back to the right diagnosis. So very important, you have to know these characteristic finding of the radiographic finding of the osteoarthritis. They might be as one of the option. What is the specific characteristic X-ray finding of osteoarthritis? This, and that. And one of them might be joint space narrowing or space narrowing of joint. Okay. I have seen it in some subscriptions, so I don't want you to lose mark for it. Osteoarthritis management. Obviously, the first best thing is education plus exercise. Why? Because the patient has to know what is this condition and what helps this condition. If he knows the condition, then he will be in a better position to take on those steps that for the betterment of his health. Foundation of the care improves pain, function, balance, and confidence. Weight management counseling if relevant. If you notice, I mentioned before that usually people with the osteoarthritis are obese, but it can happen to somebody who is fit. So if it is relevant, it means if your patient is obese, then you have to consult him on losing weight. But if the patient is fit, then you don't have to waste your time. This is what it means. Reduce knee pain, knee load, and improves function in selected patient. Topical therapies, acetaminophen trial, useful when oral non-steroid anti-inflammatory drug is high risk. So it means that we can use the non-steroid, but if the patient has some other condition that you want to prevent from further damaging the patient's health, then you have to go with the acetaminophen. Otherwise, non-steroid. Oral non-steroid only if safe. Avoid or use cautiously. Let's say if you have a patient your patient has osteoarthritis, but the patient has chronic kidney disease. The patient has GI bleeding. The patient has heart failure. The patient has blood disorder, or the patient has cardiovascular issues. So for the patient with these conditions, we try to keep the patient away from non-steroid anti-inflammatory drug because it is worsening the condition, right? In that case, we either not use it, or if we use it, we use it with a caution. And instead, we use the acetaminophen. High injection or arthroplasty referral for a persistent pain or advanced function limitation after conservative care. So again, if anyone with any kind of condition that affect his daily life, his sleep, his function in general, we have no choice but to escalate, even if it has to be a very aggressive surgery. We have to do it in order to get back the patient into the regular and routine life. Differentiate from inflammatory arthritis. Osteoarthritis, mechanical pain, brief stiffness, crepitus, bony enlargement. That's another key finding or clue. Rheumatoid arthritis is prolonged morning stiffness as opposed to this one, which is brief, less than 30 minutes. Symmetrical small joint synovitis. Usually it will be symmetrical. It will start from the small joints as opposed to osteoarthritis, which starts from the bigger joint, which is hip, knee, and spine. Septic arthritis, we have already done it. The patient will have swelling, hot, painful joint, fever, maybe, may not be positive, severe passive range of motion, very characteristic and specific. Crystal arthritis, gout, right? Acute episodic red hot. So when to refer? When do we have to refer the patient with osteoarthritis to surgery or escalate the management plan? Severe hip, knee pain, with major functional limitation. This is the key word for any surgery, okay? If somebody's functional limit, the patient has functional limitation, then you have to escalate it. Advanced radiographic osteoarthritis with patient-centered goals for function. Consider the arthroplasty referral. Do not jump to arthroscopy for degenerative osteoarthritis, degenerative osteoarthritis pain. Meniscal tear, very strongly associated with rheumatoid osteoarthritis, sorry. Okay, so meniscal tear, the category in terms of mechanism, it is twisting injury with a planted foot. Let's say you're running, you're playing as a soccer player, so your foot gets stuck, so it is planted. So the foot is not moving, like the foot is not moving, but you're getting twist from here. So this area is stationary. This is planted. Let's say this is the tibia fibula, okay? So your foot is stationary and planted, but the thigh from the above get twisted, so it is twisting the joint. When it is twisting the joint, the meniscus, which is like a cross like this, it gets teared or it gets damaged. I hope it makes sense. It is the mechanism in someone who is athlete and a young patient that who gets meniscal damage through trauma. But these meniscs can be degenerate and they will start tearing up due to degeneration, which occurs in older adult due to elderly, not adult, elderly due to osteoarthritis. That's why I mentioned before that if you have a meniscal tear or damage, always see if that happens due to trauma or due to degeneration secondary to osteoarthritis, because it is strongly associated with osteoarthritis. If you have a meniscal tear in young, most likely, like 99% of the time, it is damage. It is trauma, whether it is motor vehicle accident, whether it is motorcycle accident, whether it is just happen in the soccer field. But if it is elderly, most likely it is degenerative tear. Unless again, it is a trauma. Most likely it is degenerative, especially if your patient has osteoarthritis. So symptoms, joint line pain, this is characteristic. So they will mention, okay? They will mention the pain is in the joint line. If you hear about joint line, always think about meniscal tear. Not only that, catching, clicking, and locking. These are the key words. These are the symptoms. Please do not forget it. That's why I made it red, because this is how you can recognize that this condition might be meniscal tear. So pain in the knee, but in the joint line. Clicking, catching, locking. And swelling often happens, but it happens very slowly, and it may happen later. It doesn't happen right away. If accident happen and you have effusion and swelling right away within 1 to 2 hours, it is usually anterior cruciate ligament. Okay? Usually. Again, this is how you differentiate. This is how you differentiate. Swelling often delayed. If it happens abruptly or rapidly within 1 to 2 hours of the injury, it is anterior cruciate ligament. But if it happens slowly later on, it is usually meniscal tear, okay? Remember that. Exam, joint line tenderness, McMurray pain, click, assess anterior cruciate ligament and collateral ligament. We will do this in physical examination when we are doing the NACOS. You have to see it. McMurray is like when you're dancing with a lady. I will say it again. So this is a little bit hard to explain it. So you have to flex the arm and the hip and then extend it all the way and push it inward and extend like it is going this way, opposite. So you're pushing inward the knee and the foot outward, flexing and extending, and then switching, flexing and extending. This is how you're checking for the medial and the lateral part of the meniscus, like this. Okay, so let's say this is the knee and this is the foot. My hand is at the sole of the foot and my left hand is on the top of the patella. And the knee is bent. This is the knee. Now what I do, I flex the knee, but when I flex the knee, I push my hand inward. I'm rotating the knee inward, but the foot, I'm rotating it outward. I'm flexing and extending. One, done. Now I'm switching my hand and then flexing and extending. So it's like when you do it, it's like a movement when you're dancing with someone. I have to show you in person. It's very hard. Okay, so another thing is ligament, lateral collateral ligament, the varus and the valgus is the same thing, but you do it. You don't have to do full extension and flexion and extension. You just do this same thing, or you can just sit and do the varus and the valgus. I have to show you again. It's very hard to explain it without someone being there as a standardized patient. So again, I think somebody asked me to repeat the symptoms of the meniscus. If someone has a meniscus tear or a damage, the patient will have knee pain. But the knee pain will be in a joint line. They will mention the joint line. Joint line, one. Secondly, the patient will have catching, locking, clicking while he's moving his, let's say this is the knee, while he's moving the knee, you will see the clicking, the locking, and the catching. Like sometimes it gets stuck and then moves like this, okay? Another thing that, let's say if this is the knee, when the patient get damaged or hurt in the knee and the meniscus get damaged, the patient does not develop swelling right away, within hours. May develop swelling later on, but not rapidly within 1 to 2 hours. If someone gets hurt in the knee and develops right away swelling, this is most likely to be anterior cruciating ligament due to hemoarthrosis. Anterior cruciating ligament. If, let's say, you have a soccer player, he is running after a ball and he get hit by another player and he hold his knee and within 1 hour, his joint is swollen. This is anterior cruciating ligament until proven otherwise. I hope it makes sense. This is how you differentiate them. Now, stable tear, if you have a meniscal damage, but it is not true lock. It means it gets locked, but it opens up. It gets locked, but it opens up. If it is not a true lock, usually we do the physiotherapy. But if it is a true lock, let's say the patient flexes the knee and it gets locked. He tries to open his leg, he tries to extend the knee, but it is locked. For that patient, we need to do what? Surgery.
Sorry, Dr. Muhammad, I missed that point.
Please leave the question at the end. Please write down the question. Yeah, leave it at the end. All right. So meniscal tear is twist a squat with joint line pain. So the mechanism is when your foot is stationary, it is planted, and the joint is getting twisted. This is how it happens. And then what else? The joint line of the knee hurts. Click, lock of the knee, and also swelling may happen later on. So the most important thing to remember is the joint that hurts, if it is elderly, might be due to degeneration, meniscal tear due to degeneration, secondary to osteoarthritis. If it is young, due to trauma. It could happen after trauma for the elderly as well, but most likely osteoarthritis, you cannot forget about it. Another thing, that anterior cruciating ligament is the pivot cut landing injury with POP. When you get hurt in the same way, but you hear a pop, that pop that you hear is the rupture of the anterior cruciating ligament. Another characteristic thing, that when it happens, the patient develops swelling. Not only that, swelling happens very rapidly. Within 1 to 2 hours, the patient will have a swollen knee for the anterior cruciating ligament. So you hear a pop, then a swelling. Then when you walk, the knee is giving away. Why? Because there's no tendon. The tendon has been ruptured. So it gives away when you walk, and the patient cannot walk properly. So for the meniscal tear, swelling often happens over hours to next day, like later on. It may happen swelling, but maybe next day or the day after. But with the anterior cruciating ligament, it happens very quick, within 1 hour to 2. And that happened due to hemarthrosis. Main symptom, catching, which I mentioned before, clicking, locking. But this one, the patient will feel that my knee is not stable. It is giving away. Like when you walk, it gives away like this. Best test, McMurray test. Again, as I told you, you move your right hand and left hand the opposite direction. But at the same time, you have to do full extension, flexion and extension of the leg. For anterior cruciating ligament, you have 2 tests, but the most sensitive and specific test is Lachman test. So you have anterior drawer test. Again, it's very hard to show you guys without having somebody as a standardized patient. So what you do, you ask the patient to flex the knee, you stabilize the foot with side of your thigh, and then you hold the knee and you pull it toward yourself while the foot is stabilized. So if you feel any laxity, the anterior cruciating ligament tear is positive. But it is not that specific. The most specific is the Lachman test. The Lachman test, you ask the patient to bend the knee 20 to 30 degrees. So let's say this is the thigh, this is the knee, or maybe I should draw it. Again, I'm not a good drawer. So let's say this is the foot. This is the knee, and this is the thigh. So this degree is 20 to 30 degrees, not too much, okay? So the knee is supposed to be 20 to 30 degree bent or flex. Now, your left hand, let's say if you're standing on the other side, your left hand is going on top of the thigh. Right here. You press it downward, sorry. And the right hand is going under and not under the knee, but under like on the top of the calf. So the knee is right at the middle. This is the middle. So this is pressing downward. This is pressing upward. So it is going this way, opposite. So this is the patella, this is the knee, and this is how you do it. Sorry, I'm a bad drawer. So Lachman test is more specific if they are asking you. If you have anterior drawer test and Lachman test, always choose the Lachman test. But again, these things I have to show you in person because they will definitely be in the Nakoski station. Refer a trigger, true lock knee or persistent disabling symptoms, and This is for the true or persistent disabling symptoms. This is referral. So you have to do the surgery. Instability, active pivoting goes, associated injury, you need to do the surgery. Okay, stable or degenerative tears. Physiotherapy, quadriceps, hip strengthening, neuromuscular control. So always for any knee pain or any knee abnormality, it's always good to strengthen the muscles around them, because usually our knee get hurt or get injured when they have atrophy of the muscles, when they have weak muscle. Because if you see this, right, it is protected with a bunch of muscle around them, especially this one, which is the big one, right? So you need to strengthen them. You need to work on those muscle in order to keep the knee in its right position, to protect them like a bodyguard. So you have to work on the quads, on the hips, neuromuscular control, activity modification, analgesia. Thank you. Analgesia of safe, gradual return to activity. Avoid routine arthroscopy for degenerative tears without the true locking. Treat coexisting osteoarthritis. This is very important. Sometimes they give you very indirectly. They don't even mention the osteoarthritis. They mention, for example, chronic. The patient has chronic knee pain, right? So they just throw it somewhere, and then the question is like, what else do you have to take care? And you don't even pay attention to the, like, I know this patient has knee pain, so let's go ahead and just take care of this condition. And you forget that the patient also have the osteoarthritis that I have to take care. So be careful, especially if you have meniscal tear and the patient is an elderly. Always check for the osteoarthritis. If the patient has it, that's associated condition that you have to take care, and you have to treat the patient. Urgent referral. Obviously, we talked about this. True lock knee with a mechanical block or extension. If the patient knee is getting locked, like this patient, if it is getting locked, cannot be extended, surgery. Large traumatic tear in a young active patient. If you have a young patient and it is very severely teared, and the patient has been affected in terms of workout, in terms of life activity, obviously we have to do the surgery. Persistent disability, mechanical symptom despite the adequate rehabilitation. Suspect associated anterior cruciating ligament injury, a significant instability. For any knee pain, we have to rule out other condition, right? For example, anterior cruciating ligament, lateral collateral ligament, medial collateral ligament, and patellofemoral syndrome. Anterior cruciating ligament, I think I did mention a few things: non-contact pivot, cutting, landing, skiing, or soccer injury. Classic history: pop, like hearing something like this, pop sound, followed by a rapid swelling in the knee and knee instability. So you hear a pop, and then rapid swelling of the knee, and then you feel the knee is giving away. This is very characteristic of the knee. You have a patient, the patient came with a knee instability. The patient says that I was playing soccer, I heard a pop, and then rapidly my knee got swollen, and I came here, and I feel that my knee is giving away. This is anterior cruciating ligament. Okay. Exam, how do I examine? Anterior drawer test is commonly done, but it's not more specific. So the most specific, if they give you all this, always go for Latchman test. Very specific. Maybe limited acutely by the guarding, associated injury, meniscal tear. Always for any knee pain, we have to rule out the meniscal, the anterior cruciating ligament, the patellar fracture, the lateral collateral ligament, the medial collateral ligament, and also the patellofemoral syndrome. Imaging X-ray if fracture is concerned, MRI if diagnosis uncertain or management change. Let's say you're doing the X-ray, can't find anything. and you're still confused that what is happening. I'm not sure if this is meniscal, but it's not anterior cruciating. It is not lateral collateral ligament. It is not patellofemoral. It is not patella fracture. So in that case, it doesn't hurt if you do the MRI. All right, so ACL injury management and counseling. So now, for those of you who are doing the NAC OSCE as well, please pay attention. It is very important how you're doing the consultation and what are the sentences that you have to use and what are the points that you have to mention. Like when you mention, they have they have a chart and they just give you tick mark, tick mark, tick mark. If you don't mention it, they make a cross. When they make a cross, that's when you lose a lot of mark, because every single row that they have to tick mark is 5 out of 5. So if you get a cross, you get 0 out of 5. So acute rest from the sport, ice, compression, elevation, analgesic, protect weight bearing if needed. So this is the management. So if you have a patient, your patient has ACL. So in terms of, let's say you did the consultation, everything is done. So part of the consultation is the management plan, right? So what are the management plan? And the patient has to know it and he should expect it. So this is rest from the sport. It means the patient cannot go back to work, to exercise or support or whatever he was playing. He has to take it easy. Another thing, he can use ice, compression. He can keep the limbs elevated, analgesic, protect the weight bearing if needed. Obviously, for somebody that needs it. Learning point, control swelling and pain. So I do this to control the pain and swelling. If you're basically presenting this to an examiner, then you have to mention that why you're doing this. You have to justify it. And what's your justification for that? All these treatment to control the swelling and the pain. Early rehab, restore range of motion, activate the quadriceps, gait normalization, avoid the stiffness, and quadriceps inhibition. Prehabilitation, strength, neuromuscular training, needed whether operative or non-operative. Referral, active patient with instability or pivoting goals. Discuss the anterior cruciating ligament reconstruction after individualized assessment. So it is not required for everyone unless needed. Long-term, prevent re-injury, address meniscus and movement mechanism. Instability, increase secondary injury risk. We will discuss this more in details when we do the NAC OSCE. So the key diagnostic clue. So pay attention to this part, because if you know this, any case that you get, you will know that this is anterior cruciating ligament. Okay, it's very easy. So pop at injury, rapid effusion after injury, inability to continue the sport, because it usually happens after sport, but it can happen in motor vehicle accident. It can happen anywhere, but usually it can happen in sport. Giving away with pivoting or sudden turning. Positive Latchman with a soft endpoint. Often no fracture or X-ray despite major ligament injury. Common traps. Do not confuse delay swelling, locking with a classic anterior hemarthrosis. Do not prescribe bed rest only. Structure rehabilitation is essential. Do not ignore meniscal symptoms after ACL injury. So it means if you have ACL injury, it doesn't mean you don't have meniscal tear as well. So you have to go after that as well. Surgery is individualized, instability and activity goal matters. Patellofemoral pain. Patellofemoral pain, typical patient, usually adolescents, young adults, usually athletes, runner, volleyball player, basketball player, increased training load, someone who is intensely exercising. So usually they give you somebody who is young, who is athlete, and who is really, really intensely exercising and who is intensely using his knee. For example, running, playing volleyball, for example, playing basketball, or doing a lot of other intense exercise that requires the need to move. Symptoms. Now, how should I differentiate this in terms of location? Remember, for meniscus, we had pain in the knee, but then pain should be in a joint line, right? The joint line, they mentioned that. But this one, remember, it is very characteristic to mention that it is anterior knee pain. Anterior knee pain. Like if this is the knee, sorry, again, I'm gonna draw. If this is the knee, it's gonna be right at the anterior. That's why they call it patellofemoral syndrome. So anterior knee, please don't forget, anterior knee. Now the pain gets worse when patient uses the stairs, when the patient squats, when the patient runs, when the patient jumps, when the patient sits for a longer period of time squatting. Okay, remember when we are taking history, we're covering the OCD, PQRST, UV, AAA, right? One of those A is aggravating factor. What makes it worse? Walking on the stairs, squatting, jumping, running, playing for a long period of time. Sitting for a long period of time. Movie theater sign. Movie theater sign is another characteristic finding that is very characteristic for the patellofemoral pain syndrome. Like someone who is sitting, pain after sitting with the knee flex for a long time. That's why they call it movie theater sign, because if you're going in a movie, you're watching a movie, so usually it takes around 1 to 3 hours to finish the movie, right? So in that case, you have to keep your knee flexed, and it really bothers everybody, right? So if the pain after sitting with the knee flexed for a long time cause the pain, it is one of the characteristic finding of the patellofemoral syndrome. No effusion or instability, pain with the patellar compression. This is very important. Another characteristic findings, I made it a different color, pain with the patellar compression. So when you compress it, the patient has pain. Okay, compression of patella, pain. So adolescent, remember, adolescent, runner, or anyone who uses the knee a lot, and then the pain is in the anterior part or location of the knee, and compressing the patella makes the pain worse. If you remember these four, it is very easy to pinpoint and understand and recognize the patellofemoral sign. Adolescent, someone who is using the knee a lot, like runner, basketball player, volleyball player, soccer player, anyone who uses the knee a lot. And then the location of the pain will be in anterior part of the knee. And the pain gets worse when the patient is using stairs, jumping, running, and sitting for a long period of time. And it worsens when you compress the patella. Remember these four. And dynamic valgus may be seen. Dynamic valgus may or may not be seen, so that's why it's not very important. Diagnose clinical, no routine MRI if no locking. So we don't do MRI if no locking. We don't have to do X-ray. Why? Because it's a clinical diagnosis, unless we are ruling out mimic conditions. Effusion, instability, or red flag. No locking, trauma, effusion, instability, or red flag. If they are present, then they're red flag. Red flag. For red flag, what do? We sclate. So we can use X-ray, we can use MRI if we have to. But if you don't have red flags, no MRI. Patellofemoral pain treatment plan. Again, education always on top of your list. Please remember it, because they really love to test you on this. If you don't educate anyone, the treatment will be failed. Why? Because the patient doesn't understand the magnitude of the condition that he has, the seriousness of the condition, and he doesn't know the consequences of being compliance or non-compliance to the management regimen. Okay, so you need to educate the patient first, then you prescribe the medication in order to get a good result. It's a win-win situation for you as a professional or a medical doctor because your patient gets better. For him, it is his health or her health, right? He gets better or she gets better. So education always, because they love to test you on this one and MCQ one and also in NACOSKI. Explain load-related pain, avoid fear based on complete rest, activity modification temporarily. It is not permanent. Reduce painful stairs, hills, jumping or running volume. So basically, if he has this problem due to overdoing something, we need to cut down on that activity until he feels better and he is good enough or ready enough to restart those activity. Now, how we can make him good enough to start that activity, we have to work and strengthen the muscles around the joint, like hip strengthening, hip abductor, extensor rotator, reduced dynamic valgus, and patella stress. A quadricep strength, again, everything, any pain, any abnormality in the knee, you have to work on your thigh. You have to work on your quadriceps. You have to work on the calf. You have to build those muscle around it to hold it in place. Okay, improve the patella tracking and tolerance to function loading. Return to sport, gradual progression based on the pain response and movement quality. We can't just ask him, yeah, let's do it again, or you can go ahead and start whatever you used to do. No, we have to do it gradually. Okay, supports patellofemoral pain. Anterior. Now, these are the clues. These are very important points that you have to know. If you know it, then you should be able to recognize as soon as you read the clinical vignettes. Anterior knee pain, very characteristic. Anterior knee pain without effusion or instability. In who? In young adolescent athlete. Anterior knee pain in young adolescent athlete. Okay, without effusion, without instability. Worse with the stairs, squat, running, prolonged setting, dynamic valgus, or a poor hip control. The reason they have dynamic valgus or a poor hip control, that's why they call it patellofemoral. Normal ligament and meniscal examination suggests another diagnosis. POP rapid diffusion is, so POP rapid diffusion and stability is what? Anterior cruciating ligament. Joint line was specific for what? Meniscus. So joint line pain, locking, catching, meniscal tear. Hot swelling joints, fever, septic arthritis. Tibial tubercle pain in adolescent, Osgood Schalter disease. Tibial tubercle is very characteristic for Osgood. Tibial tubercle, Osgood, usually pediatric, right? Joint line, meniscus. Anterior knee, patellofemoral. Good. What else? I think we covered that all. So let's talk about trochanteric pain. Trochanteric pain syndrome, the category in terms of terminology, greater trochanteric pain syndrome, often, so the terminology is greater trochanteric pain syndrome, often gluteus medius, minimus tendinopathy with or without bursitis. Pain location, it is clear from its name, it's self-explanatory, lateral hip, not groin, it is lateral hip. When we do the hip joint physical examination, I will explain it more in details that when somebody comes with a joint pain, before you perform the physical examination, you pinpoint the pain in terms of location. Whereas, can you show me with your finger in which part of the hip do you have the pain? Is it in the anterior part, Is it in the lateral part? Is it in the posterior part? Because if it is in the anterior part, it is within the hip. If it is in the lateral part of the hip, it is not the hip, it is the trochanteric. If it is in the back of the hip, it is not again in the hip, it is usually in the lower back. That's radiating to the gluteus, which makes it confused, which makes the patient confused to say that this is hip pain, but it's actually lower back pain. But we will discuss it in Nakoski. And we have different special tests too, or a special physical examination to do based on that location. All right, the pain location, we talked about a trigger, stairs, standing from chair. So these are triggering the pain. When I am using the stairs, the pain worsens. When I'm standing from chair, it gets worse. Remember, these are the characteristic, these are the most important triggers that you need to remember because the patient with a lateral hip pain, if uses the stairs or standing from chair and prolonged standing, running, hip adduction, it gets triggered. It is trochanteric pain syndrome, okay? Exam point tenderness over the greater trochanteric pain with a resistant hip abduction. So you ask the patient to straighten the leg and you put your hand and ask the patient to push against your hand. Or if the patient is standing, you put your hand and ask the patient to abduct the hip and the patient will have pain. Hip range of motion usually preserve, reduce internal rotation, suggest hip osteoarthritis. So hip range of motion, usually the hip range of motion in trochanteric, it is preserved. But reduce internal rotation, if the patient cannot internally rotate the hip, it is suggesting osteoarthritis. Okay, so this is another characteristic finding for osteoarthritis in the hip, which again, it has its own special test that we have to go through while we're doing the Nakoski. Okay, the lateral hip pain, trochanteric versus hip, osteoarthritis versus lumbar stenosis. So for the pain location, lateral, for the hip, growing, deep hip may radiate to the thigh and knee, and it is an anterior part, not lateral. And lumbar stenosis, buttocks, legs, often bilateral. Provocation, side lying, stairs, resistant abduction. Abduction this way. And hip arthritis, weight bearing, and internal rotation. Internal rotation. Walking, standing is the provocation factors. Relief, avoid compression, rehab improves. Rest may help. Sitting or flexing forward helps. So lumbar stenosis, usually if they give you a scenario about this, they may not directly mention that the patient is flexing the back and he gets better, or he's extending the back and he is getting worse. What they say, the patient has back pain, which is radiating to the buttocks and the lower part of the buttocks, but it gets worse when the patient is going downstairs or when the patient is walking downhill. So now I want you to picture that what happens when you're walking downstairs. When you walk downstairs unconsciously to hold your balance, you're extending your back in order to hold your balance, not to fall down, right? So what do? You extend your back and you start walking down the stairs, right? So what happens if you extend your back, the pain worsens. But the pain gets better when the patient is going upstairs. So what happens now, I want you to picture what happens when you go upstairs. Obviously, you're holding or you're flexing your back, you're holding your posture this way. So you're flexing your back. Why? Because you need to hold your balance, right? If you're doing like this, so you're going to fall down backward. So you have to flex your back. So You have a patient, the patient have a back pain. The back pain is relating to the buttocks and low leg. And when the patient is walking upstairs, the pain is getting better. But when he is walking downstairs, the pain is getting worse. So what is that? Lumbar stenosis. They are not mentioning directly the flexion is getting better, the extension is getting worse, but indirectly they gave you something that is exactly saying this, but indirectly. I hope it makes sense. I gave you another example. They may give you a scenario about someone that who has a back pain, but he says that when I'm going for a shopping, I have a back pain. But when I'm pushing the cart, the shopping cart, I feel better. So what happens when you're pushing the shopping cart? You're flexing your back, right? You're bending your back. You're pushing it this way. So when you're pushing, you're flexing your back, then the pain goes away. You feel better. But I notice when I'm pulling the cart, my back hurts. So picture now when you're pulling something toward yourself, what do? Obviously, you're extending the back, right? If it is your back, what do? Extend the back. And now the pain comes. So walking uphill gets better. Walking downhill gets worse. Walking upstairs get better. Walking downstairs get worse. Pulling something gets better. Sorry, pushing something gets better. Pulling something gets worse. This is lumbar stenosis. Good? Okay. So exam focal lateral tenderness, preserved range of motion, reduced internal rotation. Again, internal rotation in osteoarthritis is limited. That should give you a clue that I might be dealing with the osteoarthritis. Neurological sign may be present, but usually it is not. If it is present, obviously you have to do the surgery. First step, hip abductory physiotherapy. For this one, conservative X-ray if needed. Spine focus assessment if classic. So first line, educate. See, always the first thing you need to do for any pain or any condition, educate the patient so that he knows that what is wrong with him and how important this condition is and how important is the treatment regimen to be compliance to. Education, avoid sustained compression over the greater trochanteric, activity load modification, avoid painful side lying and excessive hip abduction, progressive hip abductor strengthening and gait load retaining, analgesic if safe, treat contributors such as weak hip control. Adjunct escalate. So what can we use as an adjunctive therapy, or at what condition do we have to escalate? So, or what are the points? Steroid injection can provide short-term relief if pain blocks rehab. So if you need a short-term relief for 3 months or 12 weeks, a steroid. But you don't do that as a first line, right? You do it when all the initial pharmacological, non-pharmacological steps are exhausted. Reassess if growing pain, restricted range of motion, trauma, fever, or neurological signs appears. The red flags. Persistent disability may need imaging or specialist referral. Do not treat as hip osteoarthritis if pain is focal, lateral, and range of motion is preserved. So osteoarthritis, if the patient has pain at the anterior part of the groin and the patient has limitation in rotation, internally rotation, cannot rotate his hip. I mean the hip. Now scenario and preferred approach. This is very important. I want you guys to pay attention. So you have a scenario, then you have your approach. Typical osteoarthritis with a chronic mechanical symptoms, clinical diagnosis. This is clinical diagnosis. X-ray if the diagnosis is uncertain, severity assessment or referral planning. Uncomplicated patellofemoral, what do you do? Do you do MRI? No, we never do MRI routine. It is a clinical diagnosis and rehabilitation. So stable degenerative meniscal symptoms, physiotherapy first, avoid routine arthroscopy. True locked knee, if the knee is locked, what do you do? Urgent, orthopedic, assessment, and usually MRI. And ACL pop plus rapid swelling plus instability. Pop, swelling, instability, Latchman, clinically. MRI if the management changes. Lateral hip pain with a trochanteric tenderness, clinical diagnosis, imaging only if atypical or refractory. Findings, hard swelling joints. I don't have to say this is because we have done it already. The septic arthritis, urgent arthrocentesis, and antibiotic after aspiration if the patient is stable. After fall plus instability to bear weight is fracture, considered fracture. So the first thing you need to do is X-ray, and we do MRI if occult hip fracture is suspected. True lock, displaced meniscal tear, loose body, urgent orthopedic surgery. Pop, rapid diffusion, anterior cruciating ligament rupture plus minus meniscus because they are associated with each other. Rehab, MRI or referral depending on the function and goals. Groin pain, reduced internal rotation is osteoarthritis. Reduced internal rotation, groin pain, right? Hip focus exam, X-ray when appropriate. Night pain, weight loss, systemic symptom. It is constitutional sign and symptom. When you have constitutional sign and symptom, it means there is a high chance of having cancer, infection, inflammation, or autoimmune condition. Investigation beyond routine mechanical diagnosis. So these ones we have already discussed. I'm going to skip. Clinical vignettes. So you have a patient who has chronic knee pain, brief stiffness, 15 minutes in the morning, and has crepitus. What is the most likely diagnosis? Osteoarthritis. Older patient with a groin pain and reduced hip internal rotation. What is your diagnosis? Hips osteoarthritis. Twisting injury, joint line pain, McMurray testis positive, meniscal tear. True lock knee after twisting surgery. Pivot injury, pop, hearing, rapid hemorrhagosis, positive Latchman. What is it? What is the most likely diagnosis? Anterior cruciating ligament. Anterior knee pain, with stairs squatting prolonged sitting, and adolescent, young adult. And when you compress the patella, it gets worse. What is it? Patellofemoral syndrome or pain. Lateral hip, trochanteric tenderness, pain lying on the side, trochanteric pain syndrome. Now, the traps. Using MRI for every knee pain. This is a trap. Don't do it. Treating degenerative meniscal tear as an automatic arthroscopy. Wrong. Calling all anterior knee pain meniscus. No. Meniscus has characteristic specific location, joint line. And the patient has pain. No instability, no effusion. And usually it happens in young athlete or elderly with osteoarthritis. Missing anterior cruciating ligament injury because X-ray is normal. Anterior cruciating ligament is clinical diagnosis. You don't need X-ray for it, but you can use X-ray to rule out our other conditions. Calling lateral hip pain, hip osteoarthritis. Osteoarthritis doesn't happen in the lateral side. It happens at the front of the hip in a groin area. Ignoring the true lock knee, which is a surgery emergency. So we did discuss all this, not wasting your time. Thank you very much. Let's move on to some cases.